Dear students, as you can see on the screen, our topic today is pathology of the immune system. In my presentation, I'll focus on following issues. We'll start with definition of immunopathology, historical data, normal structure and function of the immune system, types of immunity, thermos disorders related to immune pathological conditions like accidental involution or transformation, hyperplasia, hypoplasia. Then we go to hypersensitivity reactions and autoimmune diseases. So what is it in immunopathology? It is the study of derangements in the immune system. Here you see the picture with all Nobel Prizes winners in the area of immunology. And within this list, we see our Russian scientist, Mechnikov, who studied the role of phagocytosis in immunity. It is important to know that the normal structure and function of the immune system, immunophysiology, very important to understanding pathology. You need to get familiarized with a few terms and definitions commonly used in any description of immunology. In immunopathology, we use various terms, and you must remember them. An antigen is defined as substance, usually protein in nature, which when introduced into the tissues and stimulates antibody production. Heptan is a non-protein substance which has no antigenic properties, but on combining with a protein can form a new antigen capable to form antibodies. And antibody is a protein substance produced by as a result of antigenic stimulation. Circulating antibodies are immunoglobulins, of which there are 5 classes: immunoglobulin G, A, M, E, and D. So here you see in the picture the difference between antigen and antibody. So you see the determinants on, for example, bacterial cells, and you see antibodies which combines with antigens and create the complex antigen-antibody. So here we see the picture about reactions, primary reaction antigen-antibody, and we see the complex formation, and then secondary reaction in tissues, agglutination, precipitation, immobilization, neutralization, lysis, complement fixation, which result in tissue damage in vivo. An antigen may introduce specifically sensitized cells having the capacity to recognize, react, and neutralize the injurious agent or organism. The antigen may combine with antibody to form antigen-antibody complex. The reaction of antigen-antibody in vitro may be primary or secondary phenomena. The secondary reaction induces a number of processes. In vivo, the antigen-antibody reaction may cause tissue damage, and we will try to understand the reactions in tissues in case of immunopathological reaction. I'm sure you remember the immune system, which includes tonsils, lymphatic vessels, thymus, lymph nodes, spleen, appendix, bone marrow, and lymphatic vessels. So the lymphoid tissue within various organs and tissues. Organs of immune system divided into primary one and secondary. Although functioning as a system, the organs of immune system are distributed at different places in the body, as you have already seen at above picture. These are as under primary lymphoid organs like thymus and bone marrow, and secondary lymphoid organs like lymph nodes, spleen, and mouth system mucosa, associated lymphoid tissue located in the respiratory tract or gastrointestinal system. The cells comprising immune system are as follows: lymphocytes, monocytes and macrophages, mast cells and basophils, neutrophils, and eosinophils. All these cells are involved in immune system reactions. Lymphocytes, the percentage of them in blood is between 20 and 50%. They are master of the immune system. B cells are 10-15% of cells in blood, antibody-based humoral reactions, and they transform to plasma cells. And plasma cells secrete immunoglobulins. T cells, 75-80%. Cell-mediated immune reactions are functioning with the help of T cells, which are divided into T helper cells with CD4. They are 60% of cells in blood, promote and enhance immune reactions by elaboration of cytokines. T suppressor cells with CD8 receptor, they are 30% of all blood cells, suppress immune reactions but are directly cytotoxic to antigen. And natural killer cells, NK cells, 10-50%. They are part of natural or innate immunity, cause antibody-dependent cell-mediated cytotoxicity, ADCC abbreviation. The other cell, monocytes, macrophages, are very important, about 5% of cells in blood. They are involved in antigen recognition, phagocytosis, secretory function, antigen presentation. Then we go to mast cells and basophils, up to 1% of cells in blood. They are involved in allergic reactions, wound healing. Neutrophils, 40-75%, first class of defense mechanism against microorganisms and other small antigens. And eosinophils, up to 6%. They are involved in allergic reactions, and in case of helminthiasis, they are also a diagnostic factor in case of such pathology. So again, as I said before, a lymphocyte is a master of human immune system. Morphologically, lymphocytes appear as homogeneous group. We see them under microscope as a homogeneous group of cells, but we must know that functionally there are two major lymphocyte populations, T cells and B cells, and the third type, NK or natural killer cells, which comprises a small percentage of circulated lymphocytes, having the distinct appearance of large granular lymphocytes. All three subtypes of lymphocytes are formed from lymphoid precursor cells in bone marrow as other cells of blood. Then lymphocytes undergo maturation and cell differentiation in bone marrow. We call them B cells and thymus. Then we call them T cells. And then acquire certain genetic and immune surface characters which determine their type and function. This is based on cluster of differentiation molecule on their surface. CD surface protein molecules belong to immunoglobulin superfamily of cell adhesion molecules. About 250 different surface CD molecules have been identified so far, which can be identified by CD markers by specific monoclonal antibody stain employing immunohistochemistry or by flow cytometry. So this is used by pathologists to recognize some population of lymphocytes. B and T lymphocytes proliferate into memory cells, imparting low-lasting immunity against specific antigens. While B cells differentiate into plasma cells, which form specific antibodies, T cells get functionally activated on coming in contact with appropriate antigen. Upon coming in contact with antigen, it is the macrophage, so other words, specialized antigen-presenting cell, such as dendritic cells, and the major histocompatibility complex in the macrophage, which determines whether the invading antigen is to be presented to B cells or T cells. Some strong antigen that cannot be dealt with antibody response from B cells, such as certain microorganisms like viruses, mycobacteria, tuberculosis, and other cancer cells, tissue transplantation antigen, are presented to T cells. Let's start to understand various cells, morphology and function, the cells which are involved in immunopathology reactions. Circulated monocytes are immature macrophages and constitute about 5% of peripheral leukocytes. They remain in circulation for about 3 days before they enter tissue to become macrophages. The macrophage subpopulation, like the dendritic cells found in the lymphoid tissue and Langerhans cells seen in the epidermis, are characterized by the presence of dendritic cytoplasmic processes and are active in immune system. So here you see the circulating monocytes arrow shows this cell. Monocytes and macrophages have some features and involved in various immune functions. The first, a very important function, antigen recognition. They possess cell surface receptors to several extracellular molecules, receptor for cytokines, component of complement, selectins, integrins, and Fc of antibody. These receptors recognize the organism and initiate intracellular mechanism in macrophages. Antigen, to become recognizable, can also get coated by antibodies or complement, the process being termed as opsonization. Macrophages have capacity to distinguish self from non-self by presence of human leukocyte antigens or major histocompatibility complex. Second feature, phagocytosis, antigen that had been recognized by the macrophages due to availability of above-mentioned surface receptors, or the opsonized antigen is really to be engulfed by the process of cell eating by macrophages. Then the third function is secretory function. Macrophages secrete important substances like cytokines, various cytokines, prostaglandins, which are chemical mediators of inflammation and activate other leukocytes. Secretion of protein involved in wound healing, like collagenase, elastase, fibrillase growth factor, angiogenesis factor, and others. Acute phase reactants like fibronectin, microglobulin, complement components, they are all involved in inflammation. And the fourth function, antigen presentation. When macrophages are unable to lyse the antigen or an organism, the next best course adopted by them is to act as antigen-presenting cells for presenting to immunocompetent T cells, subtype CD4, CD8 cells, or to B cells. Accordingly, the lymphoid cells would then deal with such antigen. The other group of cells, basophils and mast cells, they are a bit different. Here you see the picture, and here you see the features of such cells. They differ in their size, basophils smaller, mast cells larger. Cell shape of basophil round and mast cells oval. Nuclear shape in basophils lobated and mast cells round. And various cytoplasmic features also a bit different, and they are different in the lifespan. Basophil and mast cells are the type of circulated granulocytes, and mast cells are their counterparts seen in tissues, especially in connective tissue around blood vessels and submucosal location. Basophils and mast cells have immune globulin E surface receptor, thus in coming in contact with antigen binding to immunoglobulin E, for example, allergic reaction to parasites, these cells get activated and release granules, so they become degranulated. These granules contain substances like histamine, platelet activating factor, heparin, and certain chemical mediators. Mast cells and basophils are thus involved in mediating inflammation, in allergic reactions, and have a role also in wound healing. Let's go to neutrophils, polymorphonuclear neutrophils. Polymorphonuclear neutrophils are normally the most numerous of the circulated leukocytes, up to 70% of all blood cells. The cytoplasm of such cells contains lysosomal granules of three types: primary, secondary, and tertiary. They have similar functions to those of macrophages and are therefore appropriately referred to as macrophages, owing to their role as first line of defense against an invading foreign organism in the body. However, these cells have limitations of size and type of organism to be engulfed. So while they are capable of acting against bacteria and small foreign particulate material, but not against viruses and large particles. Eosinophils. They are also circulated granulocytes, up to 6%. These cells play a role in allergic reactions and in intestinal helminthiasis. The granules of eosinophils contain lysosomal enzymes, peroxidases, chemical mediators of inflammation. On coming in contact with immunoglobulin E opsonized antigen in case of gelmins, eosinophils degranulate and release the chemicals stored in granules and incite inflammation. HLA system and major histocompatibility complex. HLA stands for human leukocytes antigen because these antigens or genetic proteins in the body which determine one's own tissue from non-self histocompatibility were first discovered on the surface of leukocytes. Subsequently, it was found that HLA are actually gene complexes of proteins on the surface of all nucleated cells of the body and platelets. Since these complexes are of immense importance in matching donor and recipient for organ transplant, they are called major histocompatibility complex or HLA complex. Out of various genes for histocompatibility, most of the transplantation antigens or MHC are located on a portion of chromosome 6 of all nucleated cells of the body and platelets. These genes occupy four regions LOTC, A, B, C, D, on the short arm of chromosome 6 and exhibit marked variation in allelic genes at each locus. Therefore, the product of HLA antigen is highly polymorphic. The letter W in some of the genes refers to the numbers allocated to them at international workshops. So there are various class antigens. Class 1 MHC antigens have load C, S, H, L, A, B, and C, CD8 receptors. Then class 2 MHC antigen and class 3 MHC antigens. So MHC major histocompatibility complex and human leukocyte antigen HLA. They are a little bit different in their characteristics. The MHC molecule accomplishes its major role in immune recognition by satisfying two distinct molecular functions: the binding of peptides or in some cases non-peptidic molecules, and the interaction with T cells, usually via the antibody T cell receptor TCR. Role of HLA complex. HLA complex is significant in a number of ways. First, organ transplantation. Historically, the major importance of HLA system is in matching donor and recipient for tissue transplantation. The recipient's immune system can recognize the histocompatibility antigens on the donor organs and accordingly accept it or reject it. Both humoral as well as cell-mediated immune responses are involved in case of genetically non-identical transplants. The second role, regulation of the immune system. Class 1 and 2 histocompatibility antigens play a role in regulating both cellular and humoral immunity. Then association of diseases with HLA. Now we know an increasing number of diseases that have been found to have association with some specific histocompatibility antigen. These disorders include the inflammatory disorders like ankylosing spondylitis, autoimmune disorders like rheumatoid arthritis, insulin-dependent diabetes, inherited disorders of metabolism like idiopathic hemochromatosis. The exact mechanism of such associations between the disease and HLA type is not clearly understood. So you see in the picture the HLA system and loads on chromosome 6 for various HLA classes. A few words about transplantant rejection. According to the genetic relationship between donor and recipients, transplantation of tissues classifies into 4 groups. Autografts are grafts in which the donor and recipient in the same individual. Isografts are grafts between the donor and recipient of the same genotype. Allografts are those in which the donor is the same species but of different genotype. And xenografts are those in which the donor is of a different species from that of the recipient. All types of grafts have been performed in human beings, but xenografts have been found to be rejected invariably due to genetic disparity. Presently, surgical skills exist for skin grafts or for organ transplants such as kidney, heart, lung, liver, pancreas, cornea, and bone marrow. But most commonly practiced are skin grafting and kidney and bone marrow transplantation. For any successful tissue transplant without immunological rejection, matched Mayo histocompatibility locus antigen, so HLA antigen between the donor and recipient, and they are very important. The greater the genetic disparity between donor and recipient in HLA system, the stronger and more rapid will be the rejection reaction. Besides the rejection reaction, a peculiar problem occurring especially in bone marrow transplantation is graft versus host reaction. In humans, GVH reaction results when immunocompetent cells are transplanted to an immunodeficient recipient. When severe combined immunodeficiency is treated by bone marrow transplantation. The clinical feature of GVH reactions include fever, weight loss, anemia, dermatitis, diarrhea, intestinal malabsorption, pneumonia, and hepatosplenomegaly. The intensity of GVH reaction depends upon the extent of genetic disparity between the donor and recipient. Except for autografts and isografts, the immune response against allografts is inevitable. What are possible reactions in case of graft rejection? The first reaction, cell-mediated immune reactions. These are mainly responsible for graft rejections and are mediated by T cells. The lymphocytes of the recipient, on coming in contact with HLA antigens of the donor, are then sensitized in case of incompatibility. Sensitized T cells in the form of cytotoxic T cells, CD8 markers of them, as well as by hyposensitivity reactions initiated by T helper cells, attack the graft and destroy it. The second kind of reaction, humoral immune reactions. Currently, in addition to the cell-mediated immune reaction, a role for humoral antibodies in certain rejection reactions has been suggested. These include performed circulated antibodies due to pre-sensitization of the recipient before transplantation, so by blood transfusions and previous pregnancies, for example, or in a non-sensitized individual, by complement-dependent cytotoxicity, antibody-dependent cell-mediated cytotoxicity, and antigen-antibody complexes. What we see as rejection reaction. The first kind of reaction is hyperacute reaction. It appears within minutes, 2 hours of placing the transplant and destroys it. This reaction mediated by preformed humoral antibody against donor antigen. Cross-matching of the donor's lymphocytes with those of the recipient before transplantation has diminished the frequency of hyperacute reaction. The second kind reaction is acute reaction. This usually becomes evident within a few days to a few months of transplantation. Acute graft reaction may be mediated by cellular or humoral mechanisms. Acute cellular rejection is more common than acute humoral reactions. And the third kind is a chronic rejection. Chronic rejection may follow repeated attacks of acute rejections or may develop slowly over a period of months to years or so. The underlying mechanism of chronic rejection may be immunologic or ischemic. Patients with chronic rejections of renal transplant show progressive deterioration in renal function as seen by rising serum creatinine levels. Let's discuss all these reactions morphology and start with hyperacute rejection. Grossly hyperacute rejection is recognized by the surgeon soon after vascular anastomosis of the graft in case of transplantation. So surgeon can see that the organ becomes swollen, edematous, hemorrhagic, purple and cyanotic rather than gaining pink color. Histologically, the characteristic of Artus reaction are present. There are numerous neutrophils around dilated and obstructed capillaries, which are blocked by fibrin and platelet thrombin. Small segments of blood vessels may become necrotic, and there is necrosis of much of the transplanted organ, and small hemorrhages are common. So here on the skin we see the Artus reaction also with hemorrhages and necrosis of the skin. The second reaction is the acute rejection. This usually becomes evident within a few days to a few months of transplantation. Acute graft rejection may be mediated by cellular humoral mechanisms. Acute cellular rejection is more commonly than acute humoral rejection. Under microscope, the features of two forms are as under. Acute, the first one, acute cellular rejection, characterized by extensive infiltration in the interstitium of the transplant by lymphocytes, mainly T cells, and few plasma cells, monocytes, and polymorphs. There is a damage to the blood vessels and there are faults of necrosis in the transplanted tissue. Acute humoral rejections appears due to poor response to immunosuppressive therapy. It is characterized by acute rejection vasculitis and faults of necrosis on small vessels. The mononuclear cell infiltrates is less marked as compared to acute cellular rejection and consists mostly of B lymphocytes. So here you see the picture. Under microscope we see the acute allograft rejection 2 weeks after transplantation. We see typical features including mixed immunoinflammatory infiltrate, rich with eosinophils which with a moderate degree of bile duct injury. So here we see such picture. See some cell infiltrates and dystrophic changes within the liver cells. Chronic rejection may follow repeated attacks of acute rejections or may develop slowly, as I said before, over a period of months to a year or so. The underlying mechanism of chronic rejection may be immunologic or ischemic. patients with a chronic rejection of renal transplant show progressive deterioration in renal functions, and we see rising serum creatinine levels. And that is a diagnostic feature, you know. Under microscope, we see the changes like intimal fibrosis, interstitial fibrosis, tubular atrophy. Renal allografts may develop glomerulonephritis by transmission from the host, or rarely may be due to de novo glomerulonephritis. Here we see the microscopic features of chronic hepatitis pattern of mononuclear inflammation with interface hepatitis, or lobular or perivenular inflammation. C cell infiltrates and hemorrhages with dystrophic and necrotic changes within the liver tissue. So here you see various kinds of the immune system status. In case of balanced immune system, it is a normal reaction to internal and external threat. But in case of immune pathology, we see immune overreaction, and in some cases we see underreaction. So when we are talking about balanced immune system, we understand that immune system has optimal effectiveness with no over or under reactions. So what are the overreactions? In case of reaction of internal organs or tissues, we see autoimmune problem, like in case of Hashimoto thyroiditis, rheumatoid arthritis, lupus erythematosus, inflammatory bowel disease, type 1 diabetes. All these are examples of autoimmune problem. Also, against the external threat, sometimes we see allergic reactions, like in case of food sensitivities, various allergies, eczema, asthma, and allergic sinusitis. And in case of underreaction of immune system, we may see cancer growth, we see hepatitis, HIV, tuberculosis, and other cases, like a background for cancer. Also in some infections, in case of bacteria, parasites, virus, and fungi. Various types of immunity immunity or body defense mechanisms are divided into two types: humoral and cellular components. Natural or innate immunity has two major components: humoral, comprised by complement, and cellular consists of neutrophils, macrophages, and NK cells. Specific or adaptive immunity is specific and characterized by antigenic specificity, and has two main components, humoral and cellular. Humoral, formed by B cells, and cellular, mediated by T cells. So these various components of both types of immunity are interdependent and interlinked and for their functions. But we pay more attention to pathology. So immunopathology is morphological study of immune disorders which involve immunomorphology, which in addition to morphological immunological methods widely uses immunohistochemical method. Immunohistochemistry reveals the components of the immune response, establish its relationship with character morphological changes in tissues and cells. Morphological study of immune disorders also involves various characters of immune pathology, like structural expressions of various disorders. In case of antigenic stimulation or immune deficiency, we study local immune responses in sensitized organism hypersensitivity reactions. And the main forms of violation of the immune responses are insufficiency, immunodeficiency, and excessive reactions, like in case of allergy. Now we start with discovery of thymus disorders related to immune pathological conditions. There are three kinds of pathology: thymus pathology, like accidental involution or transformation, hyperplasia or hypoplasia. But starting with these issues, I would like to remind you the normal histology of thymus. In young person, we see the lobules, we see cortex of thymus, we see medulla. So, and all lobules divided by connective tissue septum. And capsule covers the thymus organ. Sometimes during autopsy of newborns, for example, we see the pathology of thymus, and we call it accidental involution. Accidentis means accidental. This is a progressive destruction of thymocytes, atrophy of the thymus in childhood. Causes of such pathology are various prolonged debilitating diseases, and outcome immune defenselessness and the development of severe infections, diseases caused by fatal viral and bacterial microorganisms. There are a few stages of involution. First, stage 1, we call it 1, moderate thymus hyperplasia in the acute phase of stress syndrome. Stage 2, focal delymphatization, other words, death of lymphocytes, and we see less lymphocytes in the cortex of the thymus lobules. Stage 3, total delymphatization of the cortex. And in that case, we see that more lymphocytes in the medulla than in cortex, like here in the picture. And we call it the stage of inversions of the layers. So more lymphocytes in the medulla, as I said before, than in cortex. It's opposite to the normal situation. So thymus lymphocytes in the medulla quantitatively prevail over cortical thymocytes, and it becomes darker than cortical in tissue sections stained with hematoxylin and erythrin. So in normal, vice versa. Stage 4, total delymphatization of thymic lobules, both cortical and medulla matter. We see death of thymic epithelial cells and a lot of Gasal borders. Here you see the pinkish Gasal, round Gasal borders. We see a lot of Gasal borders appears in territory of entire lobules, both in cortex and medulla. And stage 5, irreversible atrophic changes in thymus. And we see in that case tiny lobules and vast areas of connective tissue. So here you see the thymus involution histological feature. We see a lot of Gasal borders. We can't see difference between cortex and medulla. We see enlarged areas of connective tissue. Next pathology, atrophy of the thymus gland. It is the adverse outcome of the accidental thymus involution and the cause of acquired immunodeficiency syndrome for chronic infectious diseases and, for example, in case of immunosuppressive therapy. Due to the loss of lymphocytes and collapse of the parenchymal epithelial cells, thymus lobules reduce, thymic body calcified, connective and adipose tissue proliferate in perivascular spaces. Thymic hormones release is significantly reduced. Next pathology, opposite, thymomegaly. It is an increase in mass and volume of the thymus parenchyma above the age norm while maintaining its normal structure. This pathology may be congenital or acquired pathology. Congenital thymomegaly is detected more often in children, less often in adults. Often it is combined with malformations of the nervous and cardiovascular system, congenital dysfunctions of the endocrine system, chronic adrenal and genital insufficiency. Congenital thymomegaly, especially often seen with infection diseases, and is accompanied by generalized hyperplasia of the lymphoid tissue. The production of thymic hormones is reduced, mainly the cellular component of the immune system, as you know, which is close to congenital immunodeficiency syndrome, which is discussed before. Acquired thymomegaly occurs in young people with chronic adrenal insufficiency and is accompanied by immune disorders like congenital thymomegaly. The causes of death of patients with thymomegaly are infections and infectious allergic diseases. In connection with endocrine disorders, sudden death can occur under the influence of stress factor like medical manipulations and surgical interventions. Thymus hyperplasia, as you see on the picture, the right section of these slides, characteristic of autoimmune diseases. You see many lobules, and we see that thymus parenchyma accumulates B cells, plasma cells, lymphoid cells, and production of thymic hormones can be increased or decreased. The role of thymus hyperplasia with lymphoid follicles and the pathogenesis of the immune diseases is still unclear. It is believed that the damage to the thymus gland is one of the causes of the autoimmune process, but its secondary damage is possible. Now we go to changes in peripheral lymphoid tissue with impaired immunogenesis, and this is characteristic of antigenic stimulation and is hereditary deficiency. So here you see the picture of the lymph node with the large follicles and enlarged germinal centers. Allergy, from the Greek allos, another, is a specific hypersensitivity to antigens. We call them allergens in case of allergy reactions. As a result of an inadequate reaction of the immune system, overreaction. Allergies can manifest themselves as immediate type hypersensitivity and delayed type of hypersensitivity. Hypersensitivity is an exaggerated or inappropriate state of normal immune response with onset of adverse effect on the body. So we see overreaction and also we see following adverse effect on the body. The lesions of hypersensitivity are a form of antigen-antibody reactions. These lesions are termed as hypersensitivity reactions or immunologic tissue injury, of which 4 types are described: type 1, type 2, 3, and 4. Depending upon the rapidity, duration, and type of the immune response, these 4 types of hypersensitivity reactions are grounded into intermediate and delayed type. So here we see type 1, type 2, 3, and type 4. Type 1, we see the first contact with antigen, here in the picture the antigen and B cells and their reaction called sensitization. Then we see immune globulin E secreting plasma cells, which release immune globulin E antibodies. Then we see the activation of basophil mast cells with creating of FC receptors, and then goes muscle degranulation, and the granules secrete products involved in inflammatory reactions. Type 2, when binding of antigen and target cells with FAB or antibodies, they may result in antigen-antibody complex formation in case of tissue-specific antigen. Then goes link of FC antigen and complement and activation of complement, and then goes target cell destruction and then phagocytosis of the destroyed cells fragments. Type 3, also starting with antigen antibody binding with B cells, then complex formation, complement activation, deposition of antigen antibody complexes on the vessel wall, and then goes destruction of tissues with the help of polymorphic nuclear cells. The fourth type of the reaction, when antigen create the complex with T cells, we see the antigen presenting cells involved, then migration of antigen presenting cells to the lymph nodes, then antigen presented to CD4 and T cells, and we see tissue destruction by activated T cells and macrophages. So again, hypersensitivity reactions. The first reaction, you must know all these reactions. Immediate type, in which an administration of antigen, the reaction occurs immediately within the seconds to minutes. Immune response in this type is mediated largely by humoral antibodies, and you know these are produced by B cells or plasma cells. Immediate type of hypersensitivity reactions includes type 1, 2, and 3. Delayed type, in which the reaction is slower in onset and develops within 48 hours, and the effect is prolonged. It is mediated by cellular response, T cells mediated, and it includes type 4 reaction. Type 1, anaphylactic atopic reaction. We have already known something about this reaction. It is defined as a state of rapidly developing or anaphylactic type of immune response to antigen, or we call it allergen, to which the individual is previously sensitized. Like anaphylaxis is the opposite of prophylaxis. The reaction appears within 15-30 minutes of exposure to antigen. For example, we know such a reaction for some drugs or medication, and so all doctors must ask patients about their sensitivity to some kinds of drugs. Type 1 reaction is mediated by humoral antibodies of immunoglobulin E type or reagin antibodies in response to antigen. Although the definite cause for this form of immediate reaction to allergen is not known, but there are few hypotheses. The first one, genetic basis. There is evidence that ability to respond to antigen and produce immunoglobulin E are both linked to genetic basis. For example, there is a 50% chance that a child born to both parents allergic to an antigen may have similar allergy. Further support to this basis comes from the observation of high levels of immunoglobulin E in hypersensitive individuals and low levels of suppressor T cells that controls the immune response are observed in persons with certain HLA types, in particular HLA-B8. The second etiological factors are environmental pollutants. Another proposed hypothesis is that environmental pollutants increase mucosal permeability and thus may allow increased entry of allergen into the body, which in turn leads to raised immunoglobulin E levels. And concomitant factors and antenatal hypothesis is that allergic response in type 1 reaction may be linked to simultaneous occurrence of certain viral infections of upper respiratory tract in a susceptible individuals. The pathogenesis of type 1 reaction include participation by T, B lymphocytes and plasma cells, mast cells, and basophils, neutrophils, and eosinophils. We have already discussed such reactions. The effect of these agents are increased vascular permeability, smooth muscle contraction, early vasoconstriction followed by vasodilatation shock, increased gastric reaction, increased nasal and lacrimal secretions, increased migration of eosinophils and neutrophils at the site of local injury, as well as their rise in blood. We see eosinophilia and neutrophilia in the blood test. And examples of type 1 reactions may be skin, nose, throat, lungs, manifestation, sometimes may be severe and life-threatening anaphylaxis, common allergens which may incite local systemic type of reactions, may result in systemic anaphylaxis or local anaphylaxis. Systemic anaphylaxis, in case of administration anti-sera or anti-tetanus serum, for example, administration of drugs like penicillin, sting by a wasp or bee. The clinical features of systemic anaphylaxis include itching, erythema, contraction of respiratory bronchioles, diarrhea, pulmonary edema, pulmonary hemorrhage, shock, and death. Local, we see the hay fever, seasonal allergic rhinitis, bronchial asthma due to allergy or inhaled allergens like house dust, food allergy to ingested allergen like fish, cow's milk, eggs, etc. Cutaneous anaphylaxis due to contact of antigen with skin characterized by urticaria, wool, and flare. And angioedema, an autosomal dominant inherited disorder characterized by laryngeal edema, edema of eyelids, lips, tongue, and trunk. So here you see the skin characterized by urticaria, and flare, the local anaphylaxis. Then type 2, cytotoxic cytolytic reactions, defined as reactions by humoral antibodies that attack cell surface antigen on the specific cells and tissue and cause lysis of target cells. It appears within 15 and 30 minutes after exposure to antigen. But in myasthenia gravis and thyroiditis, it may appear after a longer duration. Type 2 reactions occurs after antibodies bind tissue-specific antigen, most often on blood cells, and various mechanisms are involved. Various kinds of antibody antigen complex activated the complement system and may attack and destroy the target cells. Examples of type 2 reactions: cytotoxic antibodies to blood cells or to tissue components. Most common examples of type 2 reactions are on blood cells, like autoimmune hemolytic anemia, in which the red cell injury is brought about by autoantibodies reaching with antigen present on red cell membranes. Antiglobulin test, direct Coombs test, is employed to detect the antibody on red cell surface. Also, as example, we know the transfusion reactions due to incompatible or mismatched blood transfusion, hemolytic disease of the newborn, also known as erythroblastosis fetalis, in which the fetal red cells are destroyed by maternal antibodies crossing the placenta. Idiopathic thrombocytopenic purpura is the immunologic destruction of platelets by autoantibodies reaching with surface components of normal platelets. Leukopenia with agranulocytosis may be caused by autoantibodies to leukocytes causing their destruction. And drug-induced cytotoxic antibodies are formed in response to administration of certain drugs like penicillin, methyl-dopa, and other drugs. The second, cytotoxic antibodies to tissue components. We know such example like Graves' disease, primary hyperthyroidism, and thyroid autoantibody formed which react with TSH receptor and cause hyperfunction and proliferation of the thyroid tissues. In myasthenia gravis, antibody to acetylcholine receptor of skeletal muscle formed, which blocks the neuromuscular transmission in the motor and plate, and that results in muscle weakness of the patient. In male sterility, anti-sperm antibodies formed which react with spermatozoa and causes impaired motility as well as cellular injury. In type 1 diabetes mellitus, islet cell or autoantibodies are formed which react against islet cell tissue. In hyperacute rejection reaction, antibodies are formed against donor antigen. Type 3, immune complex mediated Arthus reaction. Type 3 reaction results from deposition of antigen-antibody complexes on tissues, which is followed by activation of the complement system inflammatory reaction resulting in cell injury. That is important for us as pathologists as we see this cell injury. The onset of type 3 reaction takes place about 6 hours after exposure to antigen. Type 3 reaction is not tissue specific, occurs when antigen-antibody complexes fail to get removed by the body's immune system. And there can be 3 types of possible etiological factors persisting of low-grade microbial infection, extrinsic environmental antigen, and autoimmune processes. So, few details about this mechanism. The first one, persistence of low-grade microbial infection. Low-grade infection with bacteria or viruses stimulated somewhat weak antibody response. Persistence of infections, antigen, and corresponding weak antibody response leads to chronic antigen-antibody complex formation. Since these complexes fail to get eliminated from body fluids, they are instead deposited in tissues, in blood vessels, walls, in glomeruli, joint tissue, etc. And we see then a later tissue reaction for these accumulations. The second, extrinsic environmental antigen. Exogenous antigens may be inhaled into lungs, antigen derived from molds, plants, animals. The inhaled antigen combines with antibody in the alveolar fluid and forms antigen-antibody complex, which is deposited in the alveolar walls. The third mechanism, autoimmune process. Another sequence in type 3 reactions can be formation of autoantibodies against own tissues. And then we see autoantibody self-antigen complexes. They could be circulating or tissue-derived immune complexes containing both components from body's own system can then deposit it in tissue, and then we have the tissue reaction. Type 3 reactions has participation immunoglobulin G and M, antibodies involved neutrophils, mast cells, and complements, and we see the immune complexes formations, and then accumulation neutrophils, macrophages, tissue release cytokines, and then as a result we see tissue destruction. As example, we see the immune complex glomerulonephritis, in which the antigen may be from glomerular membranes or exogenous agents like streptococcus infections. We see such reaction in case of Goodpasture syndrome, again kidney glomerular membranes involved. In case of lupus erythematosus, rheumatoid arthritis, and other diseases presented here in this slide. Type 4 delayed hypersensitivity reaction is tissue injury by cell-mediated immune response without formation of antibody, but is instead a slow, prolonged response of specifically sensitized T lymphocytes. The reaction occurs about 24 hours after exposure, and the effect prolonged, which may last up to 14 days. This reaction involves the mast cells, basophils, macrophages, and CD8 T cells. Examples is following, like reaction against of mycobacterial infection in case of tuberculosis, leprosy, reaction against the virally infected cells, against the malignant cells, and against the organs transplantation. Here you see the examples of T type 4 reaction, granulomas formation. On the right picture we see tuberculosis, so tubercular granuloma with caseous necrosis in the center, epithelioid cells on periphery, lymphocytes, and specific Pirogov-Langhans cells. On the left picture we see sarcoidosis, also the granuloma formation. Few words about autoimmune diseases. Autoimmunity is a state in which the body's immune system fails to distinguish between self and non-self and reacts by formation of autoantibodies against own tissues. Immune tolerance is a normal phenomenon present since fetal life and is defined as the ability of an individual to recognize self-tissues and antigen. Normally, the immune system of the body is able to distinguish self from non-self antigens by the following mechanism: clonal elimination, concept of clonal energy, suppressor of T cells. Pathogenesis of theories of autoimmunity, mechanism by which the immune tolerance of the body is broken causes autoimmunity. These mechanisms or theories of autoimmunity may be immunological, genetical, microbial, and all of which may be interacting. So there are various immunological factors here, you see, which may cause the autoimmunity. They are presented here in this slide. Then genetic factors, which are also very important information of autoimmunity, and class 2 HLA antigen involved, and also familiar incidence of such autoimmune disorders, also very important factor. Microbial factors, very important. Some viruses, bacteria, they may stimulate autoimmune reaction. There are various kinds of autoimmune diseases, organ-specific diseases. In these, autoantibodies formed react specifically against an organ and target tissue component and cause chronic inflammatory destruction. We can see such reaction in thyroid gland, in pancreas, and in adrenal cortex, in various tissues of blood, like alimentary tract, blood cells, various other tissues. The second group, organ non-specific systemic diseases. In such diseases, a number of autoantibodies formed which react with various tissues, for example, in case of collagen diseases. Few examples like systemic lupus erythematosus, classical example of systemic autoimmune or collagen diseases. The disease derives its name lupus from Latin word meaning wolf, since initially the disease was believed to attack skin only and eat away skin like a wolf. So we see here the example of the systemic lupus erythematosus. The exact etiology is not known, but autoantibodies against nuclear and cytoplasmic component of the cells are demonstrable in plasma by immunofluorescence test, and almost in all cases of such pathology. Here you see the example, like symptoms in case of pleural in case of such disease, we see so-called butterfly rash, pleural effusions, heart problems. We see the morphology of lupus nephritis, arthritis, and Raynaud's phenomenon. Various immunological, genetical, and other factors involved in such pathology. And we know that very important autoantibodies involved in the pathogenesis of lupus erythematosus, which may cause type 2 and type 3 hypersensitivity reactions. In case of systemic lupus erythematosus, we see LE cell phenomenon. On the right picture, we see such cells. We see that such cells, as a result of the disrupted nuclei engulfed by neutrophils, displacing the nucleus of neutrophil to the rim of the cell, and we see the formation of LE cells. The manifestation of the disease is widespread. We see on the picture before the pleuritis, pericarditis, and other pathology in various organs of the patient. Histologically, the characteristic lesion of the SLA is fibrinoid necrosis, which may be seen in connective tissue, beneath endothelium on small vessels, under the mesothelial lining of pleura and pericardium, under the endothelium in the endocardium, or under the synovial lining cells of joints. So, different organs involved in case of systemic lupus erythematosus, and various features as I have already described. Scleroderma, also an example of such pathology. Diffuse scleroderma, CREST syndrome. We see calcinosis, Reynolds phenomenon, esophageal hypomotility, sclerodactyly, and telangiectasia are the features of scleroderma. Here we see the example of such pathologies. The etiology of the pathology not known, but we know that immunologic mechanisms have been implicated in the pathogenesis of such lesions. We see systemic sclerosis, which finally cause activation of fibroblasts. We see skin changes, kidney pathology, smooth muscles, skeletal muscles, and cardiac muscle, lung, and small arteries are involved. Here we see the pictures of such pathology, gross pictures of the changes within the hands of the patients, and under microscope the fibrosis and alterations seen in derma. All various organs involved in this picture. The other example, polymyositis dermatomyositis, with various pathologies involved. We see various examples of myositis, then derma pathology, and various arthritis, Reynolds phenomenon, and lung pathology, interstitial lung disease and fever are presented in these patients. We see on the face, we see edema, we see rash and other features. Histologically, we see vacuolization, fragmentation of muscle fibers, and inflammatory infiltrates. Various examples of histological features, including infiltrates within the fascicle or round fascicle, atrophic changes, and various vessel pathology. Sjogren syndrome also within such group. It has special features. You may see all these features in my lecture at LMS. Rete syndrome also has special clinical features like arthritis, conjunctivitis, urethritis. Also, immunopathologic syndrome involved. And I would like to thank you for your attention. And I ask you follow the details of this lecture at my LMS program. Thank you very much for your attention. Till next lecture. Bye.